Good morning. My name is Dr. Mehnaz A. Shafi. I'm a professor of medicine at the University of Texas, MD Anderson Cancer Center. Thank you very much for this invitation to speak today. My topic is ergonomics in endoscopy, prevention of injury to the endoscopist. Ergonomics comes from the Greek word nomio, which means natural laws, and ergon, which means work. Briefly put, ergonomics is the study of work. It has a long definition here, which is the scientific discipline concerned with understanding of interactions among humans and other elements of a system. So humans in a system, the profession that applies data and methods to design, optimize human beings and overall system performance. So this is a big mouthful. The short version is it's the study of work. So the goal of ergonomics is to optimize the interaction of the operator with his or her tools, tasks, and workforce to minimize injury and maximize efficiency. This is a general statement about work and a worker. There are certain risk factors that put you at risk for work-related strain or injury, such as repetitively doing something, prolonged awkward postures, use of high forces, contact stress, vibration. If you look at endoscopy, there are many risk factors that you can apply here. Repeated pinching or gripping of the endoscope, pushing, pulling, and torquing of the insertion tube, and working in awkward postures. This is one of the first overuse syndrome study that was done in Endoscopist. It's a very nicely done survey which was published in 1994. They surveyed 400 gastroenterologists to see if they had overuse as a result of endoscopic procedures. They had a phenomenal response rate, 72%. If you send out surveys to people, the response rate is usually 15% if you're lucky. But they had a good response rate. And this is what they said. Thumb pain, hand pain, elbow pain, low back pain, and shoulder pain possibly appear to be caused by endoscopy to at least some extent. Physicians who perform the most procedures tended to have the higher risk of developing such problems. So almost more than 40% of physicians who responded said they had experienced injury which had been chronic for more than 6 months. This was a survey where they looked at internists and they looked at those who did procedures and compared them to those who did not. So they looked at gastroenterologists and non-procedure internal medicine specialties. And again, they had a really good response rate, and the groups were quite compatible. And they found that the risk of musculoskeletal injury in the GI group was higher, 74% versus 35%, so almost double, and the p-value was significant. The common sites were thumb, lower back, hand, and neck. This study did not find any association between how much you did or how long you were doing it. So this is, I think, what I would call like a landmark paper, and it's really the only good technological review that we have to date, which was put forward by the American Society of Gastrointestinal Endoscopy almost 7 years ago. And they said, what will minimize hazards in endoscopy? And a small aspect of that was ergonomics. So they said the prevalence of musculoskeletal injury is quite a huge range, anywhere from 37 to 89%. So these complaints are more in GI people, and they're more in people who perform more than 20 endoscopies per week, which I think is a very small number compared to what we do now. 20 in a week, and according to this, put you at risk. So they looked at an ergonomic risk assessment tool called OKRA. And this looked at people who perform endoscopies, and they estimated that 10% of endoscopists will develop injury after 10 years. And overuse is due to microtrauma at the tendon, ligament level, maybe from acidosis, ischemia. Specifically to us, there is something called a colonoscopist thumb, which is a tendonitis of the left thumb due to repetitive strain. So while you're holding the dial, if you're repeatedly putting excess pressure on the left thumb by controlling the dials, this can cause pain. Similarly, there's something called a biliary endoscopist knuckle, which is a carpopharyngeal joint from making a forceful pinch and advancing catheters. So there, which is a separate injury. So also injury from forceful pushing of wires and catheters through the biopsy channel, pinch force injury. And this is not just US. I put this in to show that this is a study from Japan where they looked at endoscopists and other gastroenterologists who did not do endoscopy. And they compared injury, and they found that again frequency of pain in the hand and wrist, especially the left arm, was significantly higher in people who did endoscopy compared to the non-endoscopists. I personally like this data, and I would recommend if you would want to review this. Reddit did this study where it's a survey-based study, but he asked people questions about injury and asked them in relation to the time when they did procedure. So how do you feel now versus on the weekend when you're not doing procedures? So that was, and they found again that there was a higher rate of injury, definitely related to endoscopy, both in community practices, perhaps more so than in academic centers. The measure here also is used. They felt that more than 20 endoscopies per week put you at risk. So that just tells what we do, those who do much more than that. So they looked at what was the experience, and they looked at about 680 people, 684, and half of them said that they had had some injury related to endoscopy. Now this is self-reported, so maybe there's a bias, but it does tell you that it gives you pause for thought that this is not insignificant. And about 20% said they had required time off from endoscopy. They had half of them said they had to modify their practice in some way, either by doing less procedures, perhaps sitting down and doing procedures, and to a large extent they had required some kind of treatment. So the type of injury, we again see a pattern. It's thumb pain, shoulder pain, hand, neck, upper back pain, lower back pain, elbow, and carpal tunnel syndrome. What were the modifications people did? So, some people incorporated stretches, breaks, they adjusted their table, they did less endoscopy, they stood on rubber mats or got better shoes, they got physical therapy, rest, etc. So their conclusion was that a higher volumes was significantly associated with a higher rate of injury. Again, how many procedures you did a day also mattered. And they were not able to sort out if half a day off made it better. If you did half a day of a lot of procedures, was that the same as all day long of the same number of procedures? However, they clearly make the association between volume and injury. And the greater proportion of time spent during endoscopy was associated with a higher rate of injury. The other question that comes to mind is a longer procedure a risk factor? Maybe you're doing one, but you're doing a complicated EUS, FNA, ERCP, and it's a 2-hour, does that put you at risk? Some questions we don't know. So the one thing this showed was that colonoscopy by itself appeared to be a risk factor. So of the procedures you do, colonoscopy is one that appears to have a higher rate of association between injury. And in this particular study, they did not find that doing ERCP or EUS put you at higher risk of injury. However, there weren't that many people who did, and I think we've covered this. So in MD Anderson, we do, this is a very high volume center, high volume. A lot of our patients are very complex. They have cancer, they have malignant strictures, they are on lytics, they have neutropenia, thrombocytopenia, so long complex procedures happen. We have 14 full-time gastroenterologists, and 11 of them spend 22 hours or more per week in the endoscopy unit. We do about 1,200 procedures a month. So I informally looked at the previous 2 years and found that 3 of the 11 endoscopists had been injured. And they had significant injuries requiring time off for up to 3 months or longer, requiring surgery, requiring room change, equipment change. So not trivial strain, but significant injury. On analysis and review, I didn't go into details. Most likely it's from chronic overuse. So I wrote this article, which was published in AGA Perspectives, where I said we must ensure that the endoscopy unit is not a hazardous place for the endoscopist, because our focus always is that it should be a safe place for the patient, and that is very appropriate. But we sometimes do not focus on what is safe for the physician. And after years of practice, one of our surveys, I'll come to that, showed that after 11 years of endoscopy, you're at risk of significant musculoskeletal injury. So that all that training, and then you are. So the AGA, the American Gastroenterology Association, conducted a survey on ergonomics and endoscopy. So I was part of developing this survey, and it's a 290 item survey with drop-down menus to try and capture what is going on. And it, of course, it's a survey, it's self-reported, but it gives us some information. So we sent a survey to 10,500 people. We had a very modest response. About 826 people responded. And these were people who did at least 80% of the questions. We did not include people if they had done less than that or had done partial, and we excluded people who had not done endoscopy in the past 5 years. So 36% of the respondents were women. The median age was 47. We had someone as old as 82 years old who was actively doing endoscopy, so I thought that was nice. The thing we found was training in ergonomics during fellowship was rare. It was reported by 4.5% of all respondents. The pressure for productivity was high. 45% of people said they had been asked to increase their procedure volume in the past 2 years. So, and this was more commonly reported by women. Injury since starting endoscopy was associated with prior injury. So if someone's had prior injury, they had more risk. Procedure volume again was a risk factor, and screen height we found was a risk factor. So in people who work in rooms where the screen height is not adjustable, they associate a higher rate of injury, neck strain, back pain, etc. There are certain preventive measures which are not commonly in place, and I will talk about them, such as micro breaks. What a micro break is defined as taking 1 or 2 minutes break every 45 minutes to 60 minutes. So after, say, a procedure, you take a break, and you are not doing the procedure you were doing, or the hand maneuver, neck maneuver, back maneuver that you were doing. You take a micro break and perhaps incorporate some stretching exercises in it. So this is not commonly used, and only 13% of people had used it or knew about it. We, as I said, found an association between neck injury and those who could not adjust monitor heights. So overall rate of injury after practice was about 85%, which is really kind of discouraging. And we found certain patterns that upper body injury was more commonly reported in women, particularly wrist, shoulder, and upper back. And I won't go into details of this, but we've talked about it. So I want to spend a few minutes in just practicalities, like what can we do? So we have established that there is injury, it can happen after time. So what can we do? So I like this term called ergonomic timeout, and I want to talk about this in 3, like what do you do before procedure, during procedure, and after procedure to minimize your risk of injury. So I like the idea of ergonomic timeout. So just like you do a timeout to assess that you have the right patient, you have the right physician, you have doing the right procedure, you can spend a minute doing an ergonomic timeout in which you are saying is the equipment positioned the way I want it to be positioned before I start a procedure. So what do we mean about that? So first of all, there are certain things that are protective, such as gowns, gloves, face shields. But what I would say an ergonomic timeout is use a gel mat. So use a mat, and these are anti-stress mats. And I have done a lot of procedures without them, and I now do procedures with them. And I will tell you there is a difference at the end of the day. This is sort of a cushioning effect. So you can use a simple gel mat and stand on it. Now, how you stand is important. So OSHA and ergonomic engineers tell you that you should work in a neutral position. So you should stand in a neutral position. So the monitor, like we have two rooms today, we saw one had a very nicely adjusted monitor right in front and the other one is at an angle. So perhaps that's something to learn from. So you want to keep your neck in a neutral position. So if the monitor is here, it should be right in front of you. The monitor should not be at an angle, because at the end of 8 hours or 10 procedures, there is risk of neck strain. So maintain a good erect posture and keep your neck in neutral forward-facing position. Wear comfortable shoes, very important, especially for women. Some of the women who come are, wearing shoes that will give you neck stay. So I wear, so with like cushion padding, because it will support your spine. So keep your weight evenly balanced. Don't stand on one leg, sort of legs slightly apart stance. And the position of the monitor should be at eye level and really slightly below eye level. So right in front and slightly below. So your neck is slightly flexed down or straight, but certainly not extended. The extension position is associated with injury and strain. The distance of the screen from the endoscopist, there's a big variation. I'm not entirely sure where that comes from. This is from the technical review. Maybe it's the size of the screen or the room or the height, but there's a range that has been given. Again, like today when we did procedures, we saw, so you want to keep your upper arms in neutral position, which is like 90-degree angle. You would not like the bed to be so low that you're at 130, 150. So if I can just stand and say, so you want your arms to be like this or like this. So 90 to 100. So if the bed is too far down, you're scoping like this. So this is not ideal. So this is ideal. So bring the stretcher up so you can stand like this position. And the monitor in front of you and with the eye level slightly below eye level. So that is a good starting position to start. Now, what do you do during the procedure? So during the procedure, as much as possible, you try to maintain a neutral position of your spine and your upper extremities. And of course, we know that's not going to be 100% of the time. The neck rotation should be minimized. Like we discussed, the monitor height should be just below eye level. And I now consciously adjust this before every procedure. And I teach my fellows to do that. And it's just a good reflex habit to get into. You adjust the bed. When you hold this endoscope, use a towel or a thick 4x4 to have a wider grip rather than a pinching focus grip. So pinch more force, but if you can widen your grip, there's less tension on your digits. A two-piece apron for people who do ERCP is very important because if you wear a one-piece, you have heavy lead on your shoulders. Whereas if you wear two-piece, you distribute the weight to your waist and have less on your shoulders, less strain pressing down. So I think really two-piece shoes should be encouraged. what do you do between procedures or after endoscopy? So take micro breaks. Take a 1-2 minute break every 45 minutes, every 60 minutes. This will release, lactic buildup, muscle strain, and during this time you can do stretching exercises. And some of the ones that are you can incorporate in your procedure is like when you take the gloves off, instead of just taking them off, you can take the gloves off and stretch the glove. So you're just stretching your hand and your wrist and your upper arm. So you pull off your gloves instead of just throwing them. You pull them off and create tension, and just do this 2-3 times like that. Some people, when they take their gown off, they roll the gown off, this paper gown, and then just hold it over their head and kind of stretch it off like that. So you just arm exercise, just taking a few seconds, just make it part of your practice. I do know some people who lean against the wall and just stretch against it. So what you can do now, this is I think a slippery slope. What is the optimal volume of work? It's hard to give a guideline. We don't have great data. Of course, people may use that for well, I can't do more than that, or am I at injury? So all kinds of liability issues, and this needs to be defined. There are a lot of questions that come here, like can you do half a day with a procedure mix help? Can you do 3 colonoscopies and then an endoscopy? Would that be easier for you in terms of muscle injury? Should you limit length of procedure? So a lot of variables unknown. And I just wanted to just put a slide to say that as endoscopists, we also use a lot of desk and computer to generate reports. So take the time to sit properly, have chin parallel to the floor, sit arm length from the monitor, plant your feet, keep your wrists flat, and in my own practice in certain rooms, the space is so cramped and you're, crunched in, and these are things that should be better, or the chair is not ideal. So even in the desk and computer modules, look at that. So future area of studies where we don't know is what is the role of sedation. Do you do deep sedation, and is that causes less injury? There's exactly one study which is an abstract at DDW which seems to suggest sedation does not matter what kind, but we need more information. Does gender matter? Do certain gender, doing more in women, is that higher risk of injury? What is the optimal workload? What's the tipping point? What's the balance there? And what's the optimal interval needed? I think a very key part is training. I really encourage that this should be incorporated in fellowship programs, and they should be taught basics about just awareness and what they can do. This is also not difficult. It doesn't require necessarily, elaborate equipment, just training. Now a word about endoscopy design. So the basic endoscopy technique developments have been in high definition, in advanced imaging, resolution, but the basic design has not tremendously changed in decades, and I think there's a role to discuss that. And for example, if you look at the control dials, whether you're 4 feet 9 inches or 6 foot 7 inches, you have the same dial. So for some people, the grip is difficult, and over time, so that is an example of something that should change. Scopes that are more self-propelled, less resistance, passing of biopsy forceps channels that cause less force, minimize wrist extension, thumb force. These are things that actually we've been in discussions with a lot of devices, and they look at this. So the AG a year ago started a task force on ergonomics, and I'm the chair of that. And we have had input from Occupational Safety Health Association, content experts, environmental engineers, a lot of device companies. And if you have any suggestions or thoughts, this is my email, feel free to email me. But very briefly, just to recap, the time to chronic injury is about 11 years after endoscopy. So think of this as your long-term health. Predictors are if there's prior injury, there's a lot of procedure volume, and there's incorrect height of the endoscope. Lack of education about ergonomics is a factor that should be addressed. These are some of the recommendations that we are making and in the process of developing. So very simple: promote awareness of what is the risk and prevalence, improve design, develop criteria for ergonomically correct endoscopy suite, which means what is the protective gear you use, where should the equipment be placed, height of monitors, height of beds, and promote partnership with relevant organizations, advocacy with the industry. And I think this should be incorporated in the curriculum of trainees, how to adjust the monitor, maintain neutral position, avoid prolonged strain of wrist, hand, and thumb, use micro breaks, use anti-fatigue mats, and I said one-piece lead apron, it really should say two-piece lead apron. And we want to create partnerships with people who develop endoscopes. And at the other end, they are very receptive in incorporating ergonomic design, improving lightness of the endoscope, improving weight of it, improving use of force. So a lot of technical development is also being discussed. So I will stop there and answer any questions you may have. Thank you.